Hi, this is Michael Jordan. I'm presenting irritable bowel syndrome tonight. Irritable bowel syndrome, also known as IBS, is a gastrointestinal disorder characterized by chronic abdominal pain and altered bowel habits in the absence of any organic cause. IBS is a chronic functional disease of the bowel that affects function. Abdominal pain from IBS seriously affects the patient's everyday life and work. The prevalence of IBS in North America is approximately 10 to 15% of the general population, and it is the most commonly diagnosed gastrointestinal condition and accounts for approximately 30% of all referrals to gastroenterologists. Prevalence of IBS was 25% lower in those aged 50 years and over compared to those who were younger, so this is diagnosed early in adulthood. The overall prevalence of IBS in females was 14% compared to 9% in males. So females were more likely to have IBS and more likely to have constipation predominant IBS compared with their male peers. IBS is associated with other conditions, including things like fibromyalgia, chronic fatigue syndrome, gastroesophageal reflux disease, functional dyspepsia, non-cardiac chest pain, and psychiatric disorders, including major depression, anxiety, and somatization. Irritable bowel syndrome is a disorder of the gut-brain axis. It's diagnosed through the symptom cluster outlined in the Rome 4 criteria. And there are 8 major categories of risk factors for IBS, and they are dietary, genetic, environmental, psychological, gut microbiome, socioeconomic, physiological, and pathological. So some of the pathophysiology behind IBS, it's a little difficult to nail down from multiple sources. Several of the meta-analysis that I looked at, including the most recent up-to-date, it says despite multiple investigations, the data have been conflicting and no abnormality is specific to this disorder. One possible explanation for IBS symptoms is selective hypersensitization of visceral afferent nerves in the gut, and those can be triggered by things like bowel distension or bloating. It's unclear whether heightened sensitivity of the intestines to normal sensations is mediated by the local GI nervous system, by central modulation from the brain, or by some combination of the two. So we really don't know which way the signals are going. Are the brain driving the IBS, or the IBS driving symptoms in the brain, or both? Immunohistologic investigation has revealed mucosal immune system activation, characterized by alterations in specific immune cells and markers in some patients with IBS. Changes in the complex ecology of the fecal microflora may have led to speculation that its composition could be associated with IBS. So possibly changes in the microbiome. There's no predominant pattern of motor activity has emerged as a marker for IBS. So it's not necessarily always constipation or slowed motility or diarrhea or increased motility. So types of IBS include with diarrhea, which is IBS-D, with constipation, IBS-C, sort of a mixture of the two, which is IBS-M, and undetermined, IBS-U, though there's not a lot of information on that last one. So what do we do for IBS? So for IBS with constipation, treatment modalities include lifestyle changes, trying to encourage physical exercise, better sleep hygiene. Um, there's some brain gut behavioral therapies like CBT and guided imagery, stuff like that. Biofeedback. There are some dietary modifications that could be done to help and supplement with soluble fibers to help pull some more liquid into the stool. Along that line, also some of the medications you might see would be first line treatment is osmotic laxatives like polyethylene glycol, um, the guanylate cyclase agonists, newer prescription drugs, linaclotide or plecanatide, and there's also lubiprostone, and tenapanor. And the dosage recommendations there for the initiating doses. For IBS with diarrhea, still would begin with lifestyle changes, encouraging physical exercise and moving around, improving better sleep hygiene, the same brain gut behavioral therapies. Again, we're not sure if this is coming, if it's emotional distress that's causing this to flare up or vice versa. And again, dietary modifications. Initial treatment is usually successful, at least early on, with just over-the-counter Imodium. Take that 45 minutes before every meal. That helps slow everything down. Also, bile acid sequestrants like cholestyramine, cholestyramine, cholestyramine. Those eaten with meals, if you still have your gallbladder, or take them 2 hours after a meal and not taking it with medications if you don't have a gallbladder, because it's felt that some of those bile acids may actually irritate the bowel and cause more inflammatory response. There is also some belief that a trial run of antibiotic therapy might help. The front runner there is rifaximin. We all know from end-stage liver disease to try that 3 times a day for 2 weeks. See if that helps improve things. Allosetron also daily might help, and you sort of titrate that one up slowly as tolerated because of its side effects. And then for the global symptoms, that's the cramping, the bloating, the gas, all the things. Both types, IBS D and C. You might try hyoscamine for belly cramps. Also peppermint oil in the capsules, not from the bottle. Enteric coated capsules 2 or 4 times a day. Surprisingly, there's some success using tricyclic antidepressants, mostly for the pain, and at a very, very low dose, lower than we would give for depression, 10 milligrams at nighttime. Of course, that can still titrate up if they're still having some abdominal pain. And some of the behavioral therapies I mentioned, like the brain gut behavioral therapies, are useful in both types of IBS. This one's new to me, gut-directed hypnotherapy, also CBT, mindfulness therapy, improve both IBS symptoms and the psychosocial contributors to pain, so that helps on 2 levels. So some of the things that we would want to teach the patient, some of the things the patient and the family needs to know: they need to be educated to keep a food diary, an exercise diary, and a symptoms diary to kind of help determine if there's anything specific that's aggravating the IBS. If so, some foods may be aggravating it, um, like the FODMAP, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Um, that can be irritating and cause some IBS flare-ups. So we would want to see that in a diary. Also, if there's possible some lactose intolerance may be driving this, so avoid lactose. All of that in the diary would help us know what foods might be aggravating. If they have IBS-D, no, C with constipation, they should be eating more fiber, eat more fruits and vegetables, or consider taking fiber supplements in the form of pills or powders. Um, that'll help pull some more water in there and make the stools easier to pass. And hopefully they're passing quick enough that they're not fermenting and causing more gas and bloating. Um, certainly for IBS-C and possibly IBS-D, get regular physical activity for 20 to 60 minutes a day, at least 3 to 5 times a week. And then we want to tell them about the different medicines that are on the market that can help with diarrhea, medicines that alleviate constipation, and also that there are antidepressants that they can use for blocking some of the pain. We also have antispasmodics that'll help them with their cramping, and antibiotics that might help with some of the bloating and diarrhea if their microbiome is out of whack. So we would basically be doing some disease teaching as well as medication teaching, making sure they understand about those. We want to help them find ways to relax and cope with stress. So teaching different relaxation techniques will actually help reduce some of the stress that may be driving IBS. And we need to remind them that most people with IBS will have that for the rest of their lives. It is manageable, but it is what it is. We do want to let them know when to call us for alerts, alarms. If they see any blood in their bowel movements or bowel movements that look black, they need to call the office. If they're having diarrhea that wakes them up at night, that should not be happening. Changes in your bowel movements that do not go away, whether it's changing color, the amount, the frequency of bowel movements, etc. Belly pain that is severe or gets worse. And if they're losing any weight without trying, also any signs of infections, such as fever over 100.4 or higher, chills, all the things. These are things that we would, our must not misses that we want to rule out in our differential diagnosis. We want to make sure that we're not masking the possibility of any colon cancer or perforated diverticulitis, some of the more serious things. So in conclusion, IBS is a chronic disease that causes discomfort for many Americans. Treatment is based on the type of motility dysfunction experienced, diarrhea or constipation. Early treatment, including lifestyle modification and simple over-the-counter medications, can improve quality of life. Persistent cases may need behavioral modification therapy, stress management, and prescription drugs to manage the pain, bloating, and psychogenic causes. All my references are listed here from the information that I've quoted on each slide. And thank you very much.